So, I am Massimo Bongiovanni. I'm pleased to introduce this webinar on the role of cytology in complex CSF diagnostic. This is in the series of webinars organized by International Academy of Cytology, and I have the pleasure today to introduce you Dr. Ondřej Sobek. He's also a member of the International Academy of Cytology. Welcome, Ondřej. Dr. Sobek graduated at the University of Prague in the Czech Republic. He also got a postgraduate certificate in neurology and a certificate of the Czech Society of Clinical Cytology for performing of CSF cytological testing. And he also had a certificate in neuroimmunology. He is author of more than 100 articles, and he is also wrote 8 chapters in a monography. He worked at the Faculty of Medicine at the Charles University in Prague, and now he moved to a private lab, Topelex, that has as a main focus the diagnosis and the study of CSF. So it's a great pleasure to have you here. We have some attendees coming from Barbados and Germany. So good morning, good afternoon to everyone, and welcome, Dr. Ondřej. If someone has some question, you can write it on the chat, and at the end of Dr. Sobek's presentation, I will pose the question to the speakers. Thank you, Ondřej, and you are welcome.
Thank you for the kind introduction, Dr. Bongiovanni, and good afternoon or morning from Prague, and welcome to my presentation. I would like to mention the co-author of my presentation, Professor Jaroslava Dušková. So let me start by saying a few words about the laboratory I am head of. Our main focus is laboratory diagnostics of cerebrospinal fluid and extravascular body fluids. The subject of my presentation today is CSF cytology. However, our laboratory is a multidisciplinary workplace where pathology and cytology, clinical biochemistry, immunology, and microbiology come together to deliver complex laboratory evaluation to clinicians. In this presentation, I would like to give you an overview of CSF diagnostics. I'm going to touch upon its indications, general principles, and methods. Then I'm going to move on to CSF slides preparation and conventional staining methods used in CSF cytology. After that, I'm going to guide you through some basic CSF laboratory findings. Special emphasis will be given to the problematics of tumor cells detection in CSF, along with immunocytochemical strategies in CSF. Finally, I would like to share with you several case studies to discuss in more depth the implications of complex interpretation of laboratory findings in CSF. I guess it will take about 30 to 40 minutes to cover these issues. Firstly, allow me to further elaborate on the importance of complex CSF diagnostics. I cannot stress enough how important it is to take into consideration not only cytological expertise, but also biochemical, immunological, and microbiological data. Why is a multidisciplinary laboratory of great importance? Because all these specialties contribute with their expert knowledge to the final complex laboratory interpretation. Let's now turn to the indications of CSF diagnostics. First, we have to keep in mind there are some pre-analytical requirements for cerebrospinal fluid. First, we need a fresh sample to maximum 3 hours old and sufficient sample volume, which is sometimes not so easy in the CSF. Evaluation of cerebrospinal fluid is vital for these groups of conditions, namely neuroinflammations, intracranial hemorrhage and special subarachnoid hemorrhage, neurodegenerations, and of course, tumors impairment of central nervous system. In neuroinflammations, it is important to distinguish infectious origin from autoimmune, especially serous inflammatory cellularization in CSF includes very wide differential diagnostics from multiple sclerosis to viral or spirochetal neuroinfections. In the frame of diagnosing especially primary tumors of CNS, imaging methods such as CT scan or MRI are of course of the greatest importance. However, in meningeal infiltrations, the use of CSF cytology prevails. Moving to the next point, where I'm going to summarize general principles of CSF cytology. So let me just run over the key points here. So for CSF, there should be sterile collection tubes without any additives. Sufficient sample volume, it means 5 or better 10 milliliters when immunocytochemistry or flow cytometry is required. CSF sample must be processed in maximum of 3 hours and maintained at refrigerated temperatures in between. The need for prompt transport service should not be overlooked, since delays in laboratory analysis of CSF can cause cytolysis in hypooncotic CSF. Before slides preparation and cytological evaluation, we should virtually always know the cell count in CSF. Slides are prepared either by cytocentrifugation or cytosedimentation, followed by conventional staining methods and eventually by immunocytochemistry or flow cytometry. As I emphasized earlier, evaluation must be interpreted in the context of non-morphological investigations as well. Biochemical, immunological, and microbiological aspects are integral part of the final evaluation. In my opinion, only a multidisciplinary laboratory with 24/7 operating hours can fully comply with all these requirements for complex CSF diagnostics. This is directed to the next point, methods used in CSF cytology. For cell counting, we can use manual microscopy method with Fuchs-Rosenthal chamber, or there are automated methods available based on flow cytometry principles as well. For precise cell differentiation, of course, qualitative cytological investigation is inevitable. For cytocentrifugation, we use usually 500 microliters up to 140 Gs for 5 minutes. And then conventional staining methods like MGG, PAP, PAS, and others. For advanced cell identification in terms of lymphocyte subpopulations or identification of tumor cells, we need immunocytological methods like ICC or flow cytometry, which is of great importance, especially in leukemic or lymphoma infiltrations of central nervous system. So that was a background on CSF cytology methods. And now we are going to look in a bit more detail at CSF slides preparation and staining methods. For microscopic cell counting in Fuchs-Rosenthal chamber, just add 10 microliters of staining dilution to 100 microliters of CSF and count separately nucleated cells and erythrocytes. As basic staining in our laboratory, we use MGG, May-Greenwald-Giemsa, but of course, we can use special staining methods for detection of lipids, detection of iron. We can use hematoxylic erosin. We can use pus reaction. We can use regular microbiological methods like Gram or Zell-Nielsen. And of course, we can use, or we have to use monoclonal antibodies for immunocytological methods like ICC and flow cytometry. Looking at cellular composition of cerebrospinal fluid. Physiological components are just lymphocytes and monocytes. There could be an admixture of epithelial cells or erythrocytes after traumatic lumbar death. On the other hand, the presence of activated lymphocytes or even plasma cells, macrophages, granulocytes, tumor cells is always pathological. Well, this is a promised part of the presentation where I would like to draw your attention to some basic laboratory findings in CSF. Lymphocytic oligocytosis or pleocytosis, where the cell count is elevated. So we talk about pleocytosis, when the cell count is normal. We talk about oligocytosis. So the lymphocytic oligocytosis or pleocytosis is defined by a finding of activated lymphocytes and or even major plasma cells. Especially finding of plasma cells indicates the presence of intrathecal synthesis of immunoglobulins. Generally, this lymphocytic picture is related to the image of serous inflammation with very wide differential diagnosis. Numerical prevalence of monocytes or evidence of their activation is distinctive for monocytic oligocytosis or pleocytosis. Again, we are looking at cell count. Interception of substrate of phagocytosis is important for determination of the type of the ongoing pathological process. Unfortunately, on the contrary, without proof of the substrate of phagocytosis, it is a very non-specific finding in CSF. This image illustrates typical types of macrophagic reaction in CSF in various combinations. You can see lipophages, foamy cells, you can see fresh erythrophage. After bleeding, you can see hemosiderophages, you can see in the bottom, in the middle, you can see crystalline bilirubin. So in this slide, I would like to point out some details about macrophages in CSF. Lipophages indicates tissue destruction of CNS. We can observe this picture, for instance, in brain ischemia. Erythrophages appear after 6 to 8 hours after brain hemorrhage, namely subarachnoid hemorrhage. Hemosiderophages after, let's say, 3 or 4 days. And hematoidin, which is a crystallic bilirubin, as we have seen on the previous picture, we can observe in CSF after circa 2 weeks. Talking about granulocytes in CSF, to know the cell count is especially important for the correct interpretation of the presence of granulocytes in cerebrospinal fluid. While granulocytic oligocytosis means normal cell count, occurs in initial phase of any acute inflammatory reaction, including viral or also in early stages of brain ischemia. On the other hand, granulocytic pleocytosis is a typical sign of purulent inflammation in CSF, but only along with biochemical parameters of oxidative burns. It means low concentration of glucose and elevation of lactate in CSF. These two parameters then are building calculation of so-called coefficient of energy balance. The presence of eosinophilic granulocytes often suggests allergic, parasitic, or mycotic disease of central nervous system, but more often this is thus just reaction on shunts or breaks. In these few slides, I'm going to share images of various microbial agents which can be found in CSF. On the left side and in the middle, you can see Cryptococcus neoformans. On the left side, this is a basic stain, MGG, made by Ginza. In the middle, this is Alciandu, which visualize capsules of the Cryptococcus. And on the right side, this is just regular gram stain, and you can observe gram-positive bacteria on the background of granulocytic pleocytosis. Now we are moving towards tumor cells in CSF. This is quite extensive and complicated chapter of CSF cytology. Of course, not only of CSF cytologies. In general, it's of course complicated chapter. Because it's not a trite question to identify tumor cells in CSF. Frequently, we have to deal with difficulties arising from a specific character of CSF, especially hypooncotic character of CSF. Firstly, there is often a limited sample volume, and often means a small number of detected cells. Secondly, there might be a morphological changes due to hypooncotic CSF environment or even oncocytolysis. Just for emphasis, the total protein concentration in CSF in physiological circumstances is between 0.2 to 0.4 grams per liter. Another factor to consider is hyperactivation of cells due to inflammation. This could be especially problematic in distinguishing activated lymphocytes and lymphoma cells in CSF. Therefore, I would like to discuss the problematics of identifying of tumor cells in CSF in more detail. So, what criteria are there to consider? So, of course, it's a large cell size, nuclear irregularities, cytoplasmic irregularities, elevated nucleocytoplasmatic ratio, increased proportion of mitosis or apoptotic figures. Nonetheless, we should always bear in mind that identification of tumor cells usually can be based only on morphological parameters. And for detailed tumor cells identification in CSF, immunocytochemistry or flow cytometry is often necessary. For more details, maybe let me refer you to our paper we published together with Professor Bushkova in Brain and Behavior a few years ago. So in this slide, you are looking at immunocytochemical identification of tumor cells of mammary carcinoma in CSF. Well, when the tumor cells are unexpected or, let's say, surprising finding in cerebrospinal fluid, the identification of primary tumor is sometimes an issue. We have to use a set of various monoclonal antibodies to identify. I have included this table in my presentation to give you an overview of the most common monoclonal antibodies we use in CSF diagnostics. And now let's move on to the case studies. I would like to share with you the clinical picture, laboratory CSF results, and put them into context with the final diagnosis. Starting with acute bacterial meningitis in a 19-year-old female patient with sudden nausea, vomiting, impairment of consciousness, developed rapidly during 12 hours. We received CSF sample in our laboratory at half past 3 p.m. and in less than 1 hour, there was a basic CSF evaluation available. So you can see elevated cell count. You can see cytological picture of granulocytic pleocytosis. There was significantly elevated permeability of hemato-CSF barrier. Total protein concentration in CSF was nearly 9 grams per liter. And as I mentioned previously, the physiological range of total protein in CSF is 0.2 to 0.4. There was very low concentration of glucose and elevated lactate in CSF. So we count the parameter of coefficient of energy balance. It was in negative numbers, which indicates oxidative bursts of phagocytes, of neutrophils. However, This basic finding is just a first step of the laboratory diagnostic process and must be followed immediately by a microbiological proof of etiological agent. Final diagnosis was established, let's say, 4 hours after receiving the sample to the laboratory, and PCR detected presence of DNA of bacteria Neisseria meningitidis. Let's remember, PCR is an integral part of the complex diagnostic process here, and the prompt diagnosis would be life-saving. I cannot leave out herpes simplex encephalitis, another life-threatening medical condition. Let's not forget the possibility of hyperacute clinical course here. We can observe just few cells in CSF in terms of pathological oligocytosis, or even there could be a normal cytological finding. Always look for cytological signs of hemorrhagic necrotic inflammation, which is typical for herpes simplex encephalitis. So that means lipophages and erythrophages. And again, PCR proof of the virus is essential for the diagnosis. Neuroborreliosis is a prime example of a spirochetal neuroinfection demonstrated in the form of serous inflammatory cellularization. You can see lymphocytic pleocytosis with numerous H plasma cells. Typical is elevation of chemokine CXL13, which is B lymphocytes, chemoattractant. This finding is relatively specific for Borrelia infection. Then we have to look for the intrathecal synthesis of specific anti-Borrelia antibodies. And then this complex laboratory finding corresponds with active neuroborreliosis according to diagnostic guidelines. Multiple sclerosis is one of the most frequent autoimmune impairment of central nervous system. Besides cytological proof of plasma cells, a further diagnostic marker is the presence of oligoclonal bands of immunoglobulins. You can see the picture of isoelectric focusic pattern on the right side of the picture. And it's a typical pattern for pure intrathecal synthesis. You can see oligoclonal bands only in CSF sample and no bands in serum. So this is a proof of intrathecal synthesis of immunoglobulins, which is again incorporated in diagnostic guidelines for multiple sclerosis. The next few slides depict images of different tumor cells found in CSF. Here we are looking at medulloblastoma tumor cells in CSF. Lymphoma cells in CSF, diffuse large B-cell lymphoma is the most common type of lymphoma found in CSF. This case shows that we should never underestimate clinical history of the patient. Even seemingly minor clinical symptoms, such as headache, can originate from tumor of central nervous system, as you can see here. Simple CSF cytology is able to establish the diagnosis. So you can see carcinoma cells in CSF in this image. In CSF, we can use, of course, various staining techniques enabling us to detect tumor cells, like PAS reaction. Here you can see PAS positive tumor cells of mammary carcinoma in CSF. These images illustrate immunocytochemical proof of melanoblastoma in CSF using monoclonal antibodies against melan-A. In this slide, we are viewing immunocytochemical identification of bronchogenic carcinoma cells. Again, finding of tumor cells was surprising picture in CSF. So we have to discover the primary tumor, which was bronchogenic carcinoma. So, as I'm now approaching the end of my presentation, I would like to outline the future prospects of CSF cytology. Undoubtedly, the use of automated digital image analysis is growing rapidly. Automated cell counting, digital morphology, and flow cytometry have their significant use in CSF cytology today. But at the same time, conventional microscopy remains irreplaceable, in my opinion. Conventional microscopy cannot be replaced with these technologies, but they are complementary to conventional microscopy. They are giving us a very valuable information as well. The accelerating growth of digital methods prompted us in our laboratory to create a new web portal on our lab website, CSF Cytology Online, where scanned digital images can be sent for expert cytological evaluation as well. So let's summarize. Quantitative, meaning cell count, and qualitative cytology is an integral part of CSF examination, in terms of basic CSF examination, and in terms of full value targeted cytology, including immunocytochemistry and flow cytometry. It's necessary to follow strict pre-analytical requirements for cerebrospinal fluid. I repeat, we need a fresh native sample, maximally 2 or 3 hours old. And there could be a problem with sufficient volume and sufficient cell count. Automated methods based on digital morphology or flow cytometry are complementary and of additional value. In my opinion, in CSF diagnostic should be used in combination with conventional microscopy. And online microscopical evaluation is available in terms of telecytology. And I think that complex CSF diagnostics is job for specialized multidisciplinary CSF laboratory. Very important is mutual communications between clinician and laboratory, as well as appropriately indicated spectrum of CSF parameters. And last but not least, don't remember an expert and complex interpretation of all CSF findings, including, of course, CSF cytology. So it's all for my presentation, and thank you very much for your attention.
Thank you very much to you, Dr. Sobek, for this overview on CSF fluid. I was really impressed by the number of cases that you have. Waiting for some question from people online. I have some question for you. The first one is about the fresh material. How do you assure that all the labs send you the material in 2-3 hours? Do you have a well-organized transportation system? And how do you do in weekend or during holidays?
As you mentioned, the transport system is very important. It has to be well organized, and of course, 24 hours or 7 days a week operating hours for the laboratory is necessary, as we served as a staging laboratory for some hospitals in Prague, and university hospitals in Prague. So we have 24 hours operating hours. And of course, these pre-analytical requirements are especially important for CSF cytology. It is possible to scan the slides, as I mentioned, or send us slides just for cytological evaluation if the hospital is far away from the laboratory. So, but there must be well-organized transport service.
Yeah, so someone can prepare on site the slides and then send you the slides.
Exactly.
Yeah,
exactly.
It's a good idea. And I had the notion that we have to be careful in transportation because lymphocytes can be damaged. Is it true? How is it true?
This The oncotic cytolysis in CSF depends on the total protein concentration in CSF. So paradoxically, in neuroinflammation, so in tumor impairments, where it's elevated total protein, so the cells are well preserved usually. So we can even 24 hours after lumbar tap, we can do a valid cytology, but of course the requirements are strict. First, what we see is erythrocytolysis, erythrolysis, I think, and then of course it depends. Then of course it depends on total protein concentration, on glucose level in the CSF, etc. So it depends how long these cells, including lymphocytes, survive.
Mm-hmm. I know that you won't like this, but in case we cannot organize transportation as you did, what do you think to put the material in fixative, for example, Cytolite to perform liquid-based cytology as the extrema ratio if we cannot do that immediately, or if we don't have a possibility to have a 24 hours a day, all the day long possibility to have someone on site? Is that a good solution? Not optimal, I know, but a good solution. Do you have other suggestion?
Yeah, I think what should be done minimally is cell count. And of course, for further cytological investigation, you can make a fixation with methanol, or for flow cytometry, there are special solutions for fixation of the cells. But unfortunately, this fixation is not suitable for morphological, cytological evaluation. This fixation is good for CD markers, but the morphology is not suitable after this fixation. So I think is cell counting. It must be done, and then try to fixate the slides with methanol, and could be then kept in fridge.
Okay, thank you. I have still one question. Sorry, about tumoral CSF. You said that we have to confirm with immunohistochemistry our diagnosis. Yes, I agree. If we have really few material and we cannot, can we trust about cytological clinical correlation? Yeah. Have you ever had some kind of surprise in this correlation?
Yeah. I fully agree. Besides hypooncotic character of CSF, we have to deal with a very limited volume of the CSF sample. So of course, sometimes it's not possible to continue with immunocytochemistry, and we have to make a diagnosis just on morphological criteria. Well, I don't think. I think that it is possible to distinguish tumor cells, of course, but to identify precisely the primary tumor, because usually metastatic tumors in CNS. This is really an issue in CSF. So we can identify the tumor cells. We can say, okay, there are tumor cells, but without ICC to identify them, I think it's not very precise.
Thank you. And following my question, we have also a question from the audience. Any role in preparation and examination of cell block? This is a good question.
Yeah. Well, in CSF, we have not good experience with cytoblock. In another body fluids, this is possible, and we are dealing with cytoblocks, but in CSF, I don't recommend it. Okay, because usually you have few cells, and then once you prepare a cytospin, you have nothing left for a cell block, right? Yeah, exactly. It's the way to think of the cells, because I think the only valuable method is cytocentrifugation. If you have just few cells, and yeah, CSF is specific.
Oh yeah, I know. Specific and very difficult if you do not perform that every day.
Yeah, exactly.
Yeah, all the same seems the same. The same. Okay, so there are no other questions in the audience. So I would like to thank you again, Dr. Sobek, and also Professor Duskova to participate to this presentation. And for all the others, you have the possibility to listen that on our website in a few days, and connect again tomorrow morning at 8:30 with other people on the other side of the globe to listen again the registration of this talk. Dr. Sobek, you will be present live tomorrow after your talk?
Yes, yes, I will be.
Oh, thank you. If there are any other questions, or if you have other questions and you want to post that tomorrow, we have Dr. Sobek online. So thank you very much, everyone, for the participation, and to Alison from the ESC Central Office. Thank you, and bye.
Thank you for your invitation, and goodbye from Prague.
Bye-bye.